Hello, everybody, wherever you are. I'm Tamara Wygnanski-Jaffe, and I represent IPOSC, which is the International Pediatric Ophthalmology and Strabismus Council. And we're here today for a joint webinar on restrictive strabismus, and very happy to be with the Argentinian Society. Some of our activity is doing these joint webinars and to make, just like the World Cup, pediatric ophthalmology more a world and an international venue. So we're very happy to be here, and Jan de Farber, our president, will give you a short video. We have 6 speakers, 3 from Argentina and 3 from IPOSC from all around the world. I heard all the talks and they're fantastic. And between the talks, we will have 1 or 2 live questions, which will make this webinar more interactive. And you're all welcome to use the Q&A bar and ask more questions, which will be answered either during or after the webinar. And now I welcome the video by Jan de Farber, IPOSC president.
Dear friends and colleagues from all over the world, I'm Jan de Farber. I'm the president of the IPOSC, the International Pediatric Ophthalmology and Strabismus Council, and I would like to introduce the moderators of the Restrictive Strabismus webinar. The moderator from IPOSC is Tamara Güemes from Israel, and the local host from Argentina, Alejandro Armesto. I wish you lots of information and clinical pleasure of this webinar. Tamara and Alejandro, please go ahead and start the webinar.
Okay, thank you, Jan. And on behalf of the Argentinian Council of Strabismus, the CAI, as its council representative, and the CAI authorities, its president, Dr. Esteban Traviletti, and Drs. Polo, Zavallo, and Krugley, I'd like to thank the IPOSC for organizing this last 2022 almost Christmas joint webinar. The CAI was founded 56 years ago by a group of colleagues interested in strabismology and amblyopia, and had prominent members such as Alberto Ciancia, Nerida Melek, Julio Prieto Díaz, Lidia Gurovich, Elena Moreno de Mulet, among others. Our council is still growing as an active association in members, activities, and liaisons with other world societies. I'd like to thank the speakers of this webinar, Dr. Polo, Molinari, Gamio, Jain, Awadein, and Güemes for the presentations, and the audience for being there today. Finally, I'd like to congratulate Tamara Güemes, who is the head of the next ISA meeting that will be held in Tel Aviv in 2026. I strongly encourage everyone to attend and have the opportunity to visit her amazing country. Before starting the webinar, I'd like to ask the audience to use the Q&A tool for questions. Also, the chat resource might be used, but we prefer the Q&A. 1 or 2 questions will be answered briefly at the end of each talk, and the speakers will also be able to answer them during the whole webinar. I will say this in Spanish again. Preferimos que utilicen, por favor, la herramienta que dice Q y A para hacer sus preguntas, y al cabo de cada presentación vamos a responder, vamos a permitir que los presentadores respondan 1 o 2 preguntas brevemente, y si queda tiempo al final, también habrá más tiempo para preguntas. Thank you very much, everybody. Thank you for being there, and let's start with the webinar. I don't know, Tamara, if you would like to add something? If there's nothing further to say, the first speaker will be Susanna Gamio from Argentina. She's going to speak about Brown syndrome. Susanna, welcome.
Hello, everyone. My talk today is about Brown syndrome. The inability to elevate an eye in adduction with positive forced action test is a very frequent condition. It could be considered the common denomination of different conditions with many etiologies and variants. It may be either congenital or acquired, intermittent or permanent, unilateral or bilateral. It's very important to perform forced action bilaterally to compare. To better understand the clinical variants and the natural evolution of this condition, we conducted a study that included 56 patients at the Buenos Aires Children's Hospital. Mean age was 5 years, most of our cases were congenital, and the mean follow-up was 57 months. 17 out of 56 patients required treatment and 13 received surgical treatment. 5 patients had a spontaneous resolution. 17 children had abnormal head posture. Brown found torticollis in 35% of his 110 patients. It could be chin up, head turn, or head tilt. The pathology of this condition is generally agreed to be in the superior oblique tendon trochlear complex. Recently, it was proposed that it can be due to a congenital disinnervation disorder. This theory had been further supported by MRI findings which show hypoplasia of the trochlear nerve. Julio Prieto Diaz in 1998 described a pathogenic classification. Brown type 1 with superior oblique tendon sheath syndrome had normal superior oblique. Brown type 2, the tendon or muscle is involved and has superior oblique overaction. And the type 3, the problem is at the tendon trochlea side and have superior oblique underaction. There are acquired cases, frequently intermittent, and may be due to inflammatory processes at the trochlea. They are related to different conditions. This girl had systemic lupus, diplopia with left eye limitation of elevation and adduction and pain in the upper medial rim of the orbit, and was treated with oral steroid with good outcome. There are also secondary cases, such as a result of attacking of the superior oblique tendon in superior oblique palsy, or like this patient, post-orbital decompression surgery in Graves. Bilateral cases have active and passive limitation of elevation in adduction in both eyes and marked divergence in upgaze. Abnormal head posture is less frequent as in unilateral cases, and they usually are in orthotropia in primary position. Kostenbader and Albert were the first to mention the spontaneous improvement of Brown syndrome patients. This patient has a 25 years evolution, and without treatment, the Brown syndrome resolved spontaneously. We had a case with a delay in the appearance of symptoms in the contralateral eye. Similar cases were described by Stephen Kraft and others. Here you can see many differential diagnoses of Brown syndrome. Surgery should be indicated in those patients who present hypotropia in primary position and abnormal head posture. In relation to surgical treatment, many techniques have been described. The Crawford split tendon lengthening procedure is an available option to perform and was chosen in 11 of our patients. Here you can see a drawing of the technique. The action must be made negative for it to be effective. This patient with congenital Brown syndrome had marked intorsion of his right eye and received a chicken suture as treatment with very good outcome. In conclusion, because of the chance of a spontaneous resolution, conservative management should be the first line of treatment for patients with congenital Brown syndrome with orthotropia in primary position. If surgery is indicated, the Crawford's technique is an excellent option with excellent long-term outcome. In acquired cases, it's important to know the etiology in order to act accordingly. Finally, I show you a self-portrait of a child that highlights the importance of helping them to improve their appearance, which often involves psychosocial concern. Thank you for your attention.
Thank you very much, Susanna. I invite you to be present. I'd like to ask you something. How long do you wait until the Brown? How long do you wait for the Brown to be solved spontaneously? Do you wait usually?
If the patient has hypotropia in primary position, I want to perform surgery, but if the patient is in ortho in primary position, I wait for the spontaneous resolution.
Yeah, because I'm asking this because sometimes patients just go away and come back, I don't know, like a couple of years later, and then they don't have the Brown anymore. So I don't know if you tend to wait, or I understand you tend to operate. Tamara, would you like to ask something, Susanna?
Well, there's a question from the audience asking if you have any experience, so you know what Brown syndrome plus is.
A plus is a Brown syndrome plus with a large hypotropia in primary position.
Yes, they're asking, what is the Brown syndrome plus?
Yes, it's a Brown syndrome with marked hypotropia in primary position and superior oblique overaction.
Okay. And I think the final thing I would comment on is that there have been some documentation about self-resolution, curing Brown syndrome, not by surgery, but only by a force reduction test performed during surgery. If you have any experience with that, because in my experience, I had that happen to me twice and it looked like it was cured, but at the end, we did need to go in and do a superior oblique lengthening procedure. So if you have any experience with that, Susanna.
No, I think it's a good technique to perform, but it's not a good result for long term.
Okay, so do you want to move on, Alejandro?
No, it's okay.
Our next speaker is on the frozen globe, extraocular muscles and beyond. Our speaker is Ahmed Awadein from Egypt. So welcome, Ahmed, and we're with you.
In the frozen globe, there is severe limitation of the movement of the globe. It is caused by extensive fibrous adhesions between the sclera, muscle, and orbital soft tissues. It is usually associated with tightness and fibrosis of the extraocular muscles. Causes of the frozen globe include Congenital fibrosis of the extraocular muscles and congenital orbital fibrosis. Congenital orbital fibrosis is a more severe variant of congenital fibrosis of the extraocular muscles, but with extensive affection of all extraocular muscles and orbital tissues. Usually present as unilateral enophthalmos, ptosis, and severe limitation of the ocular movements in all directions. In congenital orbital fibrosis, there is extensive fibrous tissue formation and formation of pseudomasses connected to the extraocular muscles and sclera. The condition is sometimes associated with accessory muscles or fibrous bands. Frozen globe may also follow a severe orbital trauma with orbital wall fracture and herniation of the orbital globe. It is caused by extensive tissues. It is usually associated with tightness and fibrosis of the extraocular muscles. Causes of the frozen globe include congenital fibrosis of the extraocular muscles and congenital orbital fibrosis. Congenital orbital fibrosis is a more severe variant of congenital fibrosis of the extraocular muscles, but with extensive affection of all extraocular muscles and orbital tissues. Usually present as unilateral enophthalmos, ptosis, and severe limitation of the ocular movements in all directions. In congenital orbital fibrosis, there is extensive fibrous tissue formation and formation of pseudomasses connected to the extraocular muscles and sclera. The condition is sometimes associated with accessory muscles or fibrous bands. Frozen globe may also follow a severe orbital trauma with orbital wall fracture and herniation of the orbital fat. It may complicate orbital tumors, such as following rupture of a dermoid cyst, after removal of orbital and sinus tumors, and with some cicatrizing tumors, such as metastatic breast cancer. It may complicate multiple eye muscle surgeries with violation of the orbital fat, as well as after muscle transposition procedures. It may also occur with scleral explants, such as scleral buckle and glaucoma drainage devices. A frozen globe is typically characterized by enophthalmos and ptosis, limitation of movement in all directions that cannot be explained by paresis, subconjunctival yellow fat and conjunctival folds and shortening in iatrogenic causes. A force reduction test usually confirms the presence of a diffuse restriction. These findings, together with a probable cause, usually confirm the diagnosis. The management of such cases usually start by proper counseling of the patient. Restoration of full ocular movement is almost impossible. The main goal is achievement of acceptable alignment in the primary position. The field of binocular movement will be extremely limited after surgery, and more than one surgery is frequently needed. The objectives of surgery are to sever all the connections between the globe and the surrounding tissues, then to fix the globe in the desired position and to minimize the recurrence of such adhesions. Restriction is not only because of the tight muscles. To meticulous removal of all connections between the globe and the orbit is mandatory. Unfortunately, sometimes it has to be done blindly. You have to feel the connections between the globe and the surroundings and cut them. You should avoid scleral injury by performing small snips during cutting, by cutting in an anterior to posterior direction rather than horizontally, careful exposure, adequate drying of the field, and cautious hemostasis. You should check for the release of connections at every step by repeating the force reduction test. If still positive, you should revisit the presumed area of adhesions. If the force reduction test is still positive, you should check for posterior adhesions, and you should also explore the opposite area for a reverse leash effect, which means a limitation that is caused by posterior adhesions in the direction of limitation. Then you have to fix the globe in the new desired position. Fixation can be aided using muscles by performing a liberal recession and adding a conjunctival recession on the side of limitation, and performing a supramaximum resection or transposition opposite to the site of limitation. Remember that usually larger numbers are needed. You can also use temporary traction sutures by passing a suture under the muscle, then passed through the fornix to emerge on the skin, and then tightened on the skin or fixed with an adhesive tape. Finally, you can use some kind of permanent fixation such as periosteal fixation or conjunctival resection and caruncular fixation. Adhesions can be minimized by using topical and periocular steroids. They are mainly effective against conjunctival scarring with minimal effect on orbital fibrosis. Antimetabolites such as mitomycin C and 5-fluorouracil can also be used, either by applying them through a topical sponge, topical eye drops, or subconjunctival injections. However, the results are still controversial. Other antifibrotic drugs and aids are also available. An amniotic membrane can also be used for prevention of conjunctival and muscle adhesions, but they have little value for orbital fibrosis. Better use a cryopreserved or a fresh amniotic membrane, not a dry one. You should try to keep the stromal side toward the muscle, cover the largest possible area of sclera and muscle with minimal or no sutures. Here are a few examples of cases with frozen globe. This was a 3-year-old girl referred from a fellow strabismus colleague because of a left hypertropia and a left lower eyelid shortening. The child had 2 prior attempts to surgically correct the hypertropia. However, the surgeon was unable to hook the superior rectus muscle. The child was extremely uncooperative, presented with a very large hypertropia with the eye fixed in elevation and restricted motility in all directions. Surgical exploration showed a very positive force reduction test. A limbal conjunctival incision was performed, the superior rectus muscle was hooked, and liberally recessed. However, force reduction test was still positive after complete disinsertion of the superior rectus muscle. So the lower fornix was explored and diffuse fibrous tissue involving the inferior rectus muscle and connecting the sclera and orbital wall was found. Dissection was performed as far posteriorly as possible. Following surgery, the patient had improvement of the hypertropia, but with esotropia and limitation of the ocular movement in most directions. A second surgery was performed. The right medial rectus muscle was found to be extremely fibrotic and liberal recession was performed. Then re-exploration of the right inferior rectus muscle and right inferior oblique muscle was performed with removal of all tissues between both muscles and the orbital wall combined with a left inferior oblique myectomy. Following surgery, the patient had a better alignment of the primary position with a slightly better range of binocular movement. The second case was a 40-year-old male who had an orbital dermoid mass that was managed surgically and probably complicated with rupture during surgery. He presented with a left ptosis, a left hypertropia, and a diffuse limitation of the ocular movement. During surgical exploration, adhesions were relieved between the superior rectus, sclera, and the orbital soft tissues. A left inferior rectus recession and conjunctival recession was performed, together with transposition of both the lateral and the medial rectus muscles toward the superior rectus muscle. Following surgery, he had a good vertical alignment, but still he had a left exotropia of 25 present depth. The exotropia improved following a left medial rectus muscle resection. The third patient was a 32-year-old male who had a fungal ethmoidal sinusitis that was surgically debrided and removed 3 times. This was complicated with enophthalmos, ptosis, and a large exotropia. The exotropia was associated with limitation of ocular movements in most directions. He had a large liberal right lateral rectus recession combined with conjunctival recession and exploration and advancement of the remaining medial rectus muscle fibers, with still some residual exotropia. A modified Nishida procedure was then performed, but still the patient had residual exotropia and limitation of ocular movements in most directions. These two patients presented with congenital fibrosis with the eyes fixed in the exotropic position. The patients tended to adopt a first turn in order to achieve fixation. In both patients, bilateral lateral rectus orbital wall fixation was performed together with a unilateral medial rectus muscle resection of 8 mm. And following surgery, both patients were markedly undercorrected. A second surgery was performed in both patients. In the first patient, a bilateral medial rectus muscle resection was performed, with minimal improvement of the alignment in the primary position. In the second patient, a different approach was taken. The bilateral medial rectus muscle resection was combined with a bilateral superior oblique nasal tenotomy and medial transposition because the superior oblique muscle was found to be very tight. Post-arthroplasty, the patient had much better alignment. Thank you.
Tamara, you're muted.
Thanks, Ahmed, for this really interesting presentation. Our audience is asking if in extreme fibrosis of the superior rectus, if you're not able to hook or put a hook under the superior rectus, can you approach the superior rectus through the lid?
Well, I never tried it before. I mean, there are some recommendations of doing the inferior rectus, inferior oblique eyelid, but I've never tried it before.
All right. Adolfo, Alejandro, did you want to ask a question?
There is a question from Vanessa Source. She asks, what are the most frequent causes of bilateral acquired frozen globe without diplopia? She says like bilateral ophthalmoplegia with normal MRI and negative tests for myasthenia gravis.
Well, that's on the top of my mind. Myasthenia gravis, that would come on the top of my mind. And sometimes it does not appear on investigations, but it might show later on with some clinical testing. So I would keep looking for.
Okay. I'd like to ask you something. What is your impression regarding using antimetabolites? Do you think they work or they don't?
Actually, up to now, the results in the literature are very controversial. Most results did not find a very sufficient evidence to recommend using them. Sometimes you can use them just for the conjunctival scarring, such like using amniotic membrane and conjunctival graft, but they're not very helpful for actual orbital fibrosis for the muscles and the soft tissue around. So I don't think that we have a solution up to now for the orbital fibrosis.
Okay, thank you.
Okay, and the last question is, when you have these fibrous bands, so are you guided by some imaging, CT, MRI? And if you have the bands that are very posterior around the optic nerve and you cannot free the band and your force seduction test remains positive, do you involve an oculoplastic surgeon? Do you leave it? What do you do?
I think for the majority of the patients with accessory bands, you can retrieve them from the anterior approach just by always a conjunctiva and careful dissection. I never felt that I actually need a posterior orbital surgeon with me for these cases, but they are not that frequent, to be honest.
All right. Thanks so much for this wonderful presentation. Moving on. Next is, and have a good trip. Next is from Ecuador, Andrea Molinari, and she'll be speaking about the surgical management of congenital fibrosis of the extraocular muscles. Welcome, Andrea.
Hello, Argentina. Hello, the rest of the world. Thank you for having me again in this IPOSC webinar on restrictive strabismus. And if we are talking on restrictive strabismus, congenital fibrosis of the extraocular muscles might be among the most difficult restrictive strabismus cases to treat. And even if in many restrictive strabismus, the anatomy of the muscles can be distorted, in congenital fibrosis of the extraocular muscles, these anomalies have their maximal expression. Here you can recognize the histopathological sample of one of my patients where you can see most of the muscle fibers replaced by fibrotic tissue, which is the blue tissue. And you can see the difference compared with the normal extraocular muscles. And this profound anatomical changes makes the muscle inextensible, and this is why they cannot contract appropriately. Together with these profound anatomical changes, in these cases, you can also find very peculiar innervational aberrations, like synergistic divergence, as you can see in this girl, when she looks to the right, the left eye, instead of adducting, it abducts. Or the convergence at elevation attempt, as you can see here, the girl, when she tries to look up, both eyes converge. This makes the surgical outcome of strabismus in patients with fibrosis syndrome are really so variable. There are several papers that have shown this variable results, and this is one of them. Here you can see that they present 9 cases where they performed the same surgery in all cases, which was a inferior rectus myectomy. And you can see how in some cases, like case 1, 2, and 3, the effectiveness of the procedure is very poor compared with cases 6, 7, and 8, where the result was much better. And this high variability is also my experience. So today I'm going to show you or present you 2 cases, my best case and my worst case. This is without doubt my best case. This 11-year-old boy came to my office with this large exotropia and an almost complete ptosis. After performing a bilateral lateral rectus recession of 10 millimeters and bilateral inferior rectus recession of 8 millimeters, we got a pretty good alignment in primary position. And this is how he looked after a moderate frontalis suspensions. Remember that these patients do not have Bell's phenomenon, so you have to be very careful. So here you can see before the surgery with this very significant chin up and after the surgery. So with one procedure, strabismus procedure, and one palpebral procedure, we obtained a good result. But in this other case, this is a girl that came to see me at 1 year of age. And after a bilateral lateral rectus recession of 8 millimeters and bilateral inferior rectus recession of 7 millimeters, the strabismus was not much improved. She had a better head position, the chin up position improved, but not the strabismus. And then a re-recession of both lateral recti, 20 millimeters with a hang back suture was performed, also not much improvement. And a resection of the left medial rectus of 6 millimeters didn't help much. So after 9 years and 3 surgeries, the chin up was better, but the strabismus was pretty much the same. Fortunately, she left me to perform her a 4th surgery where I did a left lateral rectus periosteal fixation and a left medial fixation to the nasal periosteum, also a resection, but the resection did not help much. And now with the 4th surgery, the eye position improved much more. So which are the different surgical techniques used in congenital fibrosis? Well, the ones that are described are free tenotomy, myectomies, large recessions with scleral fixation or hang back sutures, resections, and periosteal fixation of the lateral rectus to the periosteum or fixation of the globe to the nasal periosteum. Are resections really useful? Here you can see this is the same patient. This is the medial rectus. As you can see, it's very transparent. They are very thin and resections on these muscles aren't really very effective. So let me show you a couple of videos where you can see the characteristic of operating these patients. Those are eyes that you have to operate very, very far back in the orbit. This is why these surgeries shouldn't be left in the hand of inexperienced surgeon. The tissues surrounding the muscles are pretty thick and very vascularized. This is why there is lots of bleeding. Look at the enlargement of the vessels on top of the muscle. This is very characteristic of these patients. Grooved hooks are very, very useful here, not only for placing the sutures, but also for cutting the muscles. And here you have to be careful. When you cut the muscle, you should cauterize first all those large vessels, because here, for example, I didn't cauterize, but then I realized that if I let the muscle go back with the muscle with such a bleeding, I would have a problem. And then I cauterized all the vessels before disinserting. Another very peculiar finding is the oblique insertion of these muscles. You can see here, one part of the insertion is much closer to the limbus than the other one. And here you have another case. I usually use teaser hooks, very thin muscles, in order to hook the tight muscles. Otherwise, a thicker hook is difficult to pass. But sometimes these very thin hooks might perforate the muscle, as you can see, as you will see here, and not hook the muscle appropriately. For example, here I hooked a part of the muscle, but then here on the left side there's another part of the muscle which looks different. It looks more tendinous, more like a band, but it's still the inferior rectus. I don't know if it was a bifid inferior rectus or it was a band next to the inferior rectus. Anyway, you have to remove that too. You have to hook this. This is what I'm doing now with a teaser hook. And then I will pass another hook in order to grab the whole muscle. Again, as you can see, you have to work very far back. And this is another groove hook, which is really, really useful in this case, as I said before, which helps you pass the suture. In this case, I'm not going to do a free tenotomy like I did in the other case. I'm going to pass the sutures, which is much easier. And look at here, the muscle, the inferior rectus was inserted 9 millimeters back. So the anomalous insertions is not only oblique insertions, but also they are not placed in the regular position. As you can see, cutting with the scissor might be difficult because sometimes you might want to use a scalpel over the hook, which makes cut the muscle more safely. And this is another characteristic. You will see that the sclera is very thin underneath the muscle. And this is why you have to be very careful when disinserting the muscle, because very easily you could cut the sclera and perforate the globe. So the goals of a surgical treatment in these patients is to improve the anomalous head posture and improve the eye alignment. Very rarely you can get a completely straight eyes in primary position. And remember, always do the strabismus surgery first and then the ptosis correction. So to conclude, remember that the surgical results in these cases are unpredictable and very, very variable. Surgery should be tailored for each case. Patients with aberrant innervation like synergistic divergence or convergence at elevation are much more difficult to improve. Beware of the ocular surface disease that these patients frequently present. So remember to lubricate these eyes very much before and after the surgery. And thank you so much for your attention.
Thank you, Andrea. Such interesting cases. We have a lot of questions from our audience. One of the first questions was, how can we explain synergistic convergence in upgaze?
Well, the synergistic convergence in upgaze, there are two different theories. One of them is that there is a simultaneous innervation of the medial rectus with the superior rectus, and the other theory is that the mechanical effect of the tightness of the inferior rectus, which are adducting muscles, produces this convergence.
Perfect. And the second question was asked by the audience, how do you perform your periostal fixation? Do you have several techniques or do you use the same technique over and over?
No, I use the same technique, and it's different to what is described in other by other authors. What I use is a baby right needle, which is the right needle that you use for frontalis suspensions, but for babies. And then I make a cut on the skin, on one of the skin creases here, and then I pass the sutures through the lateral rectus, and then with the baby right needle, I pass through the periosteum, and through the hole of the needle, I pass the sutures, and then I take it away. In that way, first, it's much easier to perform, and second, you make sure that the muscle will be against the periosteum and cannot reattach to the globe. This is the way I perform it. It's difficult to explain. At the ISA page, we have the video, so you can look at there.
Perfect. Alejandro, do you have some more questions?
You're muted, Alejandro.
Yes, I'm sorry. Yes, I'm sorry. And there's a question from Francisco Reich Almeida from Portugal. He asks, were you using a cold hook for your muscle section in your video?
In the video, yes. Hello, Francisco. Nice to have you here. In the video, I used two different grooves hooked. The first one is the right hook, which was the blue one in the first video. The problem with this hook is that it's larger, so it's a little bit difficult to pass underneath very tight muscles, and you have to buy two hooks because it's one for the right hand and one for the left side. The second I used for the second video is a much smaller hook, and this one has grooves in both sides, so you can use the same hook for placing it on one side or in the other side. And these are really very useful for these type of cases. Not only they help you place the sutures more easily, but also they help you by cutting the muscle. And as you saw in the last video, sometimes you have to use the scalpel instead of the scissor. And as Ahmed said in his previous presentation, when you cut it with a scissor, be very careful to go from the anterior part, making small cuts.
I think we have time. Okay.
Sorry?
Go ahead.
No.
I think we have time for like 1.5 more questions. So one question is, do you experience diplopia after these cases? And if so, what do you do?
No, these patients usually, as the patients you see in the mitochondrial disease, Alejandro, help me out with the name. You presented these cases very frequently. The
chronic progressive ophthalmology.
Exactly. As in those cases, these patients usually don't have diplopia.
Exactly.
Neither before, neither afterwards. And how are you going to do a half question, Tamara, now?
And the half question is, the cases of re-up, do you do the same muscles? Do you do other muscles?
Well, as you saw in my worst case, I reoperated the same muscles, but usually you don't get much. And also what I wanted to add is it's preferable to do fixed suture than hang back sutures, because what I noticed in the case where I had to do the periosteal fixation after recessing twice, the muscle crawls back forward.
I think also these cases are a spectrum and they're very different. Some are different from the other, but what is very common is the convergence and upgaze.
Exactly, and that explains why the results are so variable. The spectrum is really, sorry for my voice, and the spectrum is really very wide. And so that's why the results are variable.
Thank you.
You're welcome.
Thank you, Andrea. There are some questions you might answer using the Q&A tool. And now we are moving to Claudia Polo. Thank you, Claudia, for being with us and your presentation about Moebius syndrome. Go ahead.
Moebius is a malformative sequence defined by unilateral or bilateral facial paralysis with restricted horizontal eye movements, frequently associated with paralysis of other cranial nerves, malformations of orofacial structures, reductive limb anomalies, and defects of the chest wall like Poland anomaly. The causes of Moebius would be multiple: genetics, teratogenics like misoprostol, and ischemic like placental anomalies. But in all cases, there would be a common mechanism, the vascular disruption sequence, during the 4 to 6 weeks of the intrauterine life, and produce the stop of the development of the rhombomeres 5 and 6 with the production of the rhomboencephalodysgenesias and the aplasia or hypoplasia of the 6 and 7 nucleus of the cranial nerves. In this series of 32 cases, we analyzed the medical records with special interest in the exposure to misoprostol. We found in 22 of these the association the exposition of this medicament. So we conclude that Moebius syndrome could be caused by hypoxic ischemic disorders in the maternal fetal circulation due to vasoactive substances such as misoprostol used in our country as an abortifacient. We found in the series of 42 patients 3 ocular motility patterns. The more frequent was isotropia. The second was orthotropia with a clinical impression of horizontal gaze palsy. The less frequent was exotropia. Esotropia in 48% was a large angle in primary position, like in this patient. In 37% of the cases, esotropia was less than 50 diopters in primary position, and in 15 of the cases was esotropia with vertical elevation like DVD or forced nerve palsy. The mechanism involved seems to be a more localized lesion that affects only the ventral portion of the nucleus of the 6th cranial nerve, where the abducens neurons reside. So the interneurons subserving the medial rectus may overact, causing esotropia in these cases. In this patient, you can see esotropia with large angle in primary position, esotropia of the both eyes with preserve of the vertical gaze and complete limitation of abduction. The association with Poland anomaly, in the MRI, you can see the contracture of the medial rectus. In this girl, we can see esotropia with DVD and the limitation of abduction of the both eyes. The second pattern observed was orthotropia in primary position with a complete defect in abduction in adduction. This pattern mimics a conjugate horizontal gaze palsy. In this case, the patient has orthotropia in primary position, vertical gaze preserved, and the complete limitation to the lateral gaze. We have to distinguish between convergence and esotropia, because this patient used convergence to produce movements, especially when they try to fix near objects. You can see this effect in the video. The second patient has bilateral ptosis, orthotropia in primary position with bilateral paralysis of abduction, bilateral facial paralysis, and depression conserved, but the elevation is limited. The tip and trick in this patient is the management, the conservative management for the strabismus, because she is in primary position, and she needs a surgery for a bilateral ptosis, and with a great result because she has a Bell's positive. In these patients, the lesions is symmetrical, affecting all the entire nucleus of the cells. And the third ocular motility pattern was exotropia, and you can see these two patients, one of these with the impression of bilateral Güemes, atypical, and she has exotropia in primary position, one pattern of Y, limitation of right lateral movements, and left two. And when the left eye try to attempt the adduction, the left eye shows the upshoot, characteristic of Güemes. And this case presents exotropia, bilateral ptosis, and the impossibility to move the eyes to the center. He fixing in exotropia with right eye, and the problem with he is the absence of Bell phenomenon. For this reason, we can improve the alignment of the right eye, but we can't operate the ptosis of the left eye for complications with the cornea. The strabismus surgery in Moebius sequence have the next goals: correct head turn anisotropia and don't produce consecutive exotropia, correct and prevent the corneal exposure and the lesions associated with the lag of thalamus, and correct the ptosis. The techniques that we have to do that are large recess of the medial rectus, large recess of the medial rectus associated with transposition, and we can talk about the intraoperative management in this restrictive strabismus. The position under general anesthesia in the preoperative is show the restriction of the medial rectus, since the esotropia remains in the same amount as with the awake patients. There are different levels of contracture of the medial rectus that we can observe careful the force reduction test, because they are positive but in different grades in both eyes. The intraoperative examination is essential to dynamically calculate the amount of recess of the medial rectus. And the tip and tricks of this is we recommend the use of the right hooks to facilitate the taking the medial rectus, the passage of the suture, and the cut of the muscle. The Kere test is shortening the muscle, don't reach the insertion, the original insertion. Force induction test becomes negative after disinserting medial rectus. There is a variable degree of contracture of the rectal medial rectus that is determined according to the position under anesthesia and the force induction test. I perform a large medial rectus reset according to the deductions under anesthesia, trying to achieve a balance of passive forces in orthotropia. We have to avoid remaining in exo or iso at the end of the surgery, since this position achieved under anesthesia is the one that will be achieved after. The tip and tricks in this is the evaluation of the scleral indentation of the suture. We have to avoid this sign. And I did the conjunctival recess. The results post-surgical are stable and satisfactory. We get the alignment in primary position and corrected the face turn. When the orthotropia can be achieved, we have to add other technique like transposition. I use a transposition of the superior rectus lateral rectus with a recess of the medial rectus and Nishida technique. I prefer currently Nishida technique with a medial rectus recess. And to conclude, the main tips in Moebius sequence are the evaluation and treatment of corneal conjunctival exposure, the treatment of amblyopia, managing strabismus, ptosis, and refractive errors, and the surgical treatment according to ocular motility pattern, angle of deviation in primary position, and head turn. Thank you so much for the invitation.
Thank you very much, Claudia. We'll invite you now to answer some questions. There's a question here from Vanessa Source. She says, I have a 5-year-old girl with acquired bilateral facial paralysis and esotropia without limitation. What do you think about this case?
With respect to the treatment, Vanessa?
She can't
It's a
answer.
Moebius syndrome. It's a Moebius syndrome. So
It says that there's no limitation, yeah.
There is no limitation, but
Yeah.
in primary position is north or is in
It's esotropia.
isotropia.
Without limitation.
Yes. With facial paralysis.
Yeah.
Yes. Theoretically, to define Moebius syndrome, the motility of horizontal gaze can be altered, had to be altered. So you have to analyze this isotropia. But and you can check the total movement to the abduction, because in some cases the abduction is partially limited, not total. But it is only esotropia with any restrictive component. Maybe it's an association, but not Moebius.
And Clau, I have a question for you. Did you have any patient with diplopia after surgery?
No, I don't. I don't know any with diplopia before and after. Yes, with overcorrection, but no diplopia. They don't have a stereopsis and don't have a binocular vision, so the suppression is so intense, so diplopia is not usual.
Tamara, would you like to ask something?
So Claudia, when you do your recession, and you say you do an 8 to 12 medial rectus recession, do you just see where the muscle goes and sits back, or how do you decide, because they're so contracted anyways, how do you decide if it's a 8 or 9 or 10 or 12?
The decision is based in the forduction test. The amount of the recession of the medial rectus, I calculated in the dynamic form, trying to get a balance between adduction and abduction during the under the surgery and in passive way, obviously, similar to a spring-back forces after the recession. And in the position that I get this orthotropia under anesthesia is the point where I put the muscle.
Okay, so if you get a consecutive exotropia, it's pretty difficult to go back to the
yes,
to a medial rectus advance in these cases.
In my experience, if you achieve orthotropia under anesthesia, the patient will be in the same after anesthesia. But if under anesthesia the patient is in exo, it's overcorrect. You have to move the muscle again and put in orth.
Okay, and the second question is, did you ever have a pull-in-2 case in these cases where the muscle just tore off from the insertion?
Yes, I don't have any cases,
Okay.
but I think it's a big possibility to do because the muscles are so contracted, and if you don't have experience to take this muscle so restricted, you have to do it, the complication.
Okay.
Okay, thank you very much, Clau.
Thank you so much for the
Okay.
invitation.
Thank you, Claudia. Our next presentation will be on the principles of surgery for incomitant strabismus given by Saurabh Jain from the United Kingdom. Welcome, Saurabh. Nice to see you.
Good morning. Thank you very much for the kind invitation to speak. I'm going to talk about the challenges in the management of incomitant strabismus. Incomitant strabismus, simply put, is strabismus that differs according to the direction of gaze. So here you have a patient who has a small exotropia in primary gaze, which is more in right gaze and less in left gaze. On the whole, incomitant strabismus is acquired and associated with diplopia. So you classically see incomitant strabismus due to neurological causes or due to mechanical limitation, be it things like thyroid disease or trauma, and in some special congenital forms such as Güemes and Brown syndrome. I'm going to present a few cases that illustrate the rules I use in the management of incomitant strabismus. Now, this is a 15-year-old girl who complains of vertical diplopia as long as she can remember. She's finding it difficult to read for long periods and is about to go to university, thereby causing her a significant amount of anxiety. Looking at her ocular motility, you can see she has a right over left that is significantly more in left gaze. Now, anytime you want to assess a squint and make a surgical plan, I feel two things are important: the ocular deviation and the ocular motility. So the motility here shows a right superior oblique palsy with all the associated sequelae, and this is the deviation. When you are presented with a chart like this with the 9 gaze, I usually like to look at the horizontal, then the vertical, and then the torsional measurements. And you can see here this patient has a V pattern esotropia of about 22 diopters, but much more interestingly, she has a vertical strabismus and extraocular torsion that are all most pronounced in levo depression. So we need to work on the muscles that work more in levo depression, which would be the right superior oblique or the left inferior rectus. How to decide can be assisted by looking at accessory investigations like the Hess chart, and here you can see there's a significant right superior oblique underaction, which is much more advanced than any other muscle. Also, if we now look at this patient's superior oblique tendon, you can see the superior oblique tendon is really loose and the eye can be pushed all the way back into the orbit, thereby suggesting the superior oblique might be the best option to operate on. So this girl had a superior oblique tuck procedure, which you can perform either by using a tendon tucker or in my case, just a squint hook. And what you're really looking for is pre-op when you have a nice lax tendon. When you have finished, you want to be able to just push the eye so that it clears a line formed drawn between the two canthi. So this patient had a really good outcome, and here it really is a case of doing the right operation for the right patient on the right muscle. And this is my first rule: try and target the muscles that move the eye in the direction of maximum deviation, if at all possible. Here's another case: a 62-year-old Caucasian woman who's a high myope and complains of horizontal diplopia, making it difficult to drive, but she's okay for near. The vision is fine, the fundus is fine. There's what she looks like. So not a big deviation here. But if you look at her measurements, you can see she is at distance esotropia, and also esotropia is more in right gaze. So now we need to choose a muscle to work on. Looking at our muscles that move the eyes in the directions of cardinal gaze, the deviation is most in right gaze. You might want to do something on the left medial rectus or the right lateral rectus. So which would be better? Well, we have to be aware, if you're going to do a medial rectus, I usually like to do a hangback recession, and you have to be aware of the secondary effects of extraocular muscle surgery. So a recession is the most effective in the direction of action of the weakened muscle, whereas a resection produces a leash effect, which is the greatest away from the direction of the muscle. So here, if we did a right LR procedure, you get the most effect in left gaze. The deviation is actually most in right gaze. Thereby, a left MR recession would be a much better procedure that would give you an effect in primary position, but also when the patient uses that muscle and looks to the right where the deviation is the most. Therefore, this is my second rule: be aware of the secondary effects of your surgery, and you can use them to your advantage. Here's the third patient. This patient is a right esotropia with hardly any abduction. So no prizes for guessing. This is the right sixth nerve palsy. And what are we going to do? Well, again, we look at the measurements, because the measurements are most in right gaze. So we need to work on the muscles that move the eye right. However, this is the nomogram I use for surgical treatment of sixth nerve palsy, and it all comes down to the lateral rectus function. If there is no function of the lateral rectus, there is no point in using that muscle. So this can be assessed in two ways: either by doing a force generation test in clinic, or by using toxin to the medial rectus to see how much abduction you get. If there is no lateral rectus function, it's best to perform a transposition procedure. These are the kind of things we used to use before, but this is my method of choice, in which you do an MR recession and you move the SR down to the LR and put in a posterior fixation suture. It's an excellent paper by Reshma Mendal and Linda Dagi. This is what I did. This is what I did for this patient with a very good outcome. You see his hair, he is post-op, anything is slightly exophoric, but maintains very good alignment, and he has good abduction now in right gaze. So this is my third rule: if there's no function in a paralyzed muscle, borrow one that does work. Now, for sixth nerve palsies, I prefer to use the modified Nishida procedure, which is even more non-invasive. Here's another case. It's a gentleman who underwent surgery to his left eye for a retinopexy by using a peribulbar block. And looking up, he now can appreciate diplopia. So you can see the left up gaze is limited, and looking at the measurements of the motility, you can see there's a significant limitation of left up gaze, which is probably due to a tight IR because of injection of anesthetic within the muscle. This can be further elucidated by doing a force duction test. So here I am pushing the eye down and it's free, but it'll try and push the eye up, and you can see that's the tight IR that is not letting your muscle come up. So in this case, I performed an IR recession, and here I'm dividing the ligament of Lockwood, which you absolutely have to do every time you recess the inferior rectus, because otherwise you will end up with a lid malposition. So the reason this gentleman developed this limitation of elevation is because the myotoxicity of bupivacaine in the initial degeneration of the myofibrils is followed by a hypertrophied large muscle complex into a tight inelastic muscle. So this is my rule number 4. If there's a restriction or mechanical limitation, aim to release it if at all possible before proceeding any further. And this is my last case. This is a gentleman with a thyroid disease who has had bilateral orbital decompression and an IR recession on the left eye, and now has a left over, and now you can see he has a right over left that is significantly more in down gaze, but he he is maintaining good alignment in primary gaze. So this is a bit of a challenge. And here, what you really want to do is you want to match the limitation in down gaze. And you can do this by using a retroequatorial myopexy procedure or a Scott's procedure, where you do a simultaneous recession and resection of the same muscle. You do selective action, weakening of the action of the operated muscle in the direction of action, but no effect in primary gaze. The advantage of a Scott's over a Fardin's procedure is that it's adjustable. So this is my rule number 5. If it's not possible to release the limitation, at least then aim to match it in the contralateral eye, which will give you a good outcome. So in summary, incompetent strabismus is a surgical challenge and patient need to be counseled appropriately. Target the muscles that move the eyes in the direction where the deviation is the greatest. If there is a restriction or mechanical limitation, aim to release it if possible. If it's not possible to release limitation, aim to match it in the contralateral eye. If there is no function in a paralyzed muscle, transpose one, that does work, and be aware of the secondary effects of your surgery. Thank you very much for your attention.
Thank you very much, Saurabh. Tamara?
Saurabh, a question for you. Do you use Botox in these cases as well as a primary, as an add-on?
Yes, thank you very much. Yes, I absolutely do. So I used Botox either as a diagnostic procedure, so you can use them in your sixth nerve palsy before you do the procedure to see if there's any function in the LR. So you do it 2 weeks before the surgery and see if you get any more abduction. But you can also use it therapeutically, so almost like a chemical traction switcher. So if you're doing a big recession in a muscle and you really want to weaken it further, I think it's quite helpful to use toxin at the same time, although long-term it may not have a significant effect. And of course, it also helps to temporize measures. So, if you have a patient with an acute palsy or an acute deviation and you're waiting for it to settle before you operate, I think it's a really good thing to use to make the patient more comfortable in the intervening period.
Okay, another question from our audience is, do you use absorbable or non-absorbable sutures on the inferior rectus? And do you use adjustments or not?
That's such a good question. And when I started as a new attending, I used to use absorbable sutures and adjust. And I found the inferior rectus is a very tricky muscle. If you don't get all lid retractors off completely, there's a very good chance that you'll get late overcorrection. So I now tend to use non-absorbable sutures, and I use the semi-adjustable technique of Dr. Holmes. So I put a vital suture in the center that I can use to pull the muscle up a little bit if I need to, but most of the time I use a non-absorbable suture.
And you don't find those expose themselves through the conjunctiva a few years after?
So they tend not to. I like Ethibond. Sometimes I use Proline if I can't get Ethibond, and that does seem to work well. And they're quite deep in the fornix, usually during a recession. So, and you can cover them with Tenon. So I've not had an exposure yet.
All right, Alejandro, do you have any?
Saurabh, do you have experience regarding Horta Barbosa's innervational surgery for these cases, for paralysis?
I don't, I'm afraid.
Okay. Thank you. There is another question. How is your plan for adjustable fan resect half of recession? I don't know. Maybe they are referring to a Scott's
yes.
technique.
Yeah.
Yes. Again, that's another thing which I'm not sure if there are any nomograms. Something maybe might be a good research project for somebody to work on. So I can tell you how I calculate my Scott's procedures. So I calculate to see what is the amount of deviation I want to correct. So say there's a patient that got nothing in primary gaze, but they're 15 diopters in 15 diopters of esotropia in left gaze. You want to do something on the right MR to match that. So I divide the amount of prism diopters by 3 to give me an idea of how much recession I want to do. So that's step number 1. Step number 2, recession is always more than resection. And now we have a number of recession. So then the number of recession into 2 is equal to the amount of resection into 3. For example, so if it was say 15, so I would do 5 millimeters of recession, and 5 times 2 is almost 3 times 3. So I would do 5 of recession and 3 of resection on the MR. So that's what I use, but I know everybody's a bit different.
Thank you. Well, if there are no further questions, thank you very much, Saurabh. And we are moving to Adolfo Güemes from Argentina. He's going to speak about Graves' disease.
Today, we're going to talk about strabismus in thyroid eye disease. So we know that thyroid eye disease is an autoimmune disease produced by antibodies and autoantigens produced by insulin-like type 1 receptors overexpressed in orbital fibroblasts, B and T cells that produces functional complexes that get hyaluronic acid accumulation and cytokine expression, which produces inflammation and edema, the expansion of extraocular muscles and adipose tissue. Clinically, thyroid eye disease produces double vision. It's usually painless, binocular, initially intermittent. This is a 45-year-old female who presented with double visions worse in the morning, just waking up. You can see the eyelid retraction in down gaze, the pseudophone grave sign. And if you see the CT images, you can compare the size of the superior rectus complex on the right and the left orbit, and you can see the difference, which can tell you that it's a thyroid disease early in the beginning of the process. Motility is a restrictive non-commitant strabismus. It's like a dog in a leash because it starts really fast and stopped abruptly in the movement of the eyeball. The landmark here are the positive forced actions. We do that intraoperatively. And the saccadic velocity usually is pretty normal in comparison with other eye muscle diseases like ocular motor palsies, which are very affected early on. Usually, you need to know that this is a progressive disease. It's very important to ask about smoking, just because these patients get much more severe disease, starts with edema or swelling of the lids at the beginning with erythema, and sometimes it's only lids manifestations rather than ocular manifestations. Due to progression, you have to be aware of optic neuropathy. This is an 85-year-old female who complained of blurred vision. You can see the superior lids are really retracted by the age, with bilateral discs, edema, with hemorrhages, but optic neuropathy can present without optic disc edema and the affected visual fields. Usually, the risk factors for optic neuropathy, compressive optic neuropathy in Graves' disease, like described by Feldon, are this radiologic with optic apex crowded of the optic nerve. But we found that clinically severe bilateral limitation in that case is another sign of risk factor for getting a compressive optic neuropathy. Another imaging sign of optic neuropathy is rectified optic nerve. This is a patient with bilateral optic compressive neuropathy, and she really had a rectified optic nerve on the CT scan. Usually these patients are being treated for glaucoma with eye drops, and usually the pallor here in compressive neuropathy is different than glaucoma. Usually it's more pallor than excavation with a pale rim, and that's why it's important to get intraocular pressures in down gaze and in primary position to get the difference between glaucoma and restrictive strabismus that produces compression of the eye globe. Imaging, CT is enough, but with MRI and fat suppression with contrast, you can see the details of the eye muscle enlargement, but CT coronas without contrast is is really enough. And you can get the coronals, which is much better to compare the sizes of the muscles in the two different orbits rather than getting sagittal or axial cuts. So coronals is very important to get difference between eye muscle size between one orbit and the other one. You can present also with no lid retraction. This is a 65-year-old male with double vision for 4 years, a history of transient ischemic attack with thrombophilia. It didn't have much eyelid retractions, just an upgaze limitation. And we found intraoperatively that they had positive force reductions. We did surgery, and after surgery, we asked for images, and we found in eye muscle enlargement with high antibodies of thyroid. Another case, 68-year-old male with 2 bypass surgery, double vision for 5 months, thyroid, and intraoperatively we found that he really had a tight muscle with the inferior rectus recession. And after that, we asked for images. We found inferior rectus that it was enlarged without eyelid retraction. Asymmetry can be another one, another characteristic of these thyroiditis patients. This is a 55-year-old female with right orbital exophthalmos on eye muscle enlargement. We did surgery, orbital decompression, and strabismus surgery. She did fine, and 4 years later, she came up with a left orbital exophthalmos with eye muscle enlargement. We did, again, decompression and eye muscle surgery, and she did fine. So you have to be aware that thyroiditis is always bilateral. It's a matter of time, so you have to act accordingly if you have a very asymmetric orbital disease between one and the other one. Differential diagnosis, ocular myasthenia gravis. There's almost 5% of patients which can coexist between thyroiditis and ocular myasthenia gravis. You have to think about those cases that we have unilateral ptosis or very asymmetric eyelid retraction. Carotid cavernous sinus fistula, it also presents with bilateral exophthalmos, with high intraocular pressure, double vision, and restricted ocular motility. Here, arterialization of the vessels. The key here is the cerebral arteriography, which is the key to confirm the diagnosis. MRI and MRA does not confirm the diagnosis here. So even if whenever you suspect carotid cavernous sinus fistula, you have to ask for cerebral arteriography. Ocular moropalsy is another differential, but usually here the saccadic are really affected and much slower. These are the steps. First, decompression, then strabismus. We found that 16% of our patients had double vision after orbital decompression. So we have to always warn the patients that after decompression, they can get strabismus and double vision with the posterior floor and medial orbital wall decompression. And this is a complication of a really aggressive left orbital decompression of the floor and medial wall that was done elsewhere, and very tough to correct in the double vision in these situations. Treatment in the acute phase for thyroid disease, we didn't get very good experience with periocular steroids. We are now doing IV steroids every week, and the gold standard now is in the US and other developed countries is the teprotumumab IGF inhibitor. When to operate, not in the acute phase, just usually said to wait 6 months, but it can be even longer. Just make sure to measure and remeasure the patient over and over again, and make sure that he doesn't have any chemosis or any other sign of active or acute active disease. Technique, surgery, muscle recessions. We do not add any kind of restrictive procedure like resections. Even if they have torsional diplopia, I've never done in almost 200 cases any kind of oblique surgery. Just by correcting the vertical muscles, you can correct also the torsional diplopia. I'm now avoiding adjustables. These are very tight muscles. You can get slipped muscles if you're doing adjustables. Very useful to get the right hook. This is a hook that is, well, was now patented by Ken Wright. Very useful for inferior rectus when you're suturing. It's very tough when you're suturing sometimes through the muscles, not to get sclera in between. Usually it's very tight, the sclera and the muscle. So this is very useful to protect the sclera when suturing the muscle. Prisms, I only use it for incomitant strabismus, and yeah, that's usually the case after surgery. If there's a small undercorrection, you can get some prisms. Not botulinum toxin in fibrosed or swollen muscles, so I don't use botulinum toxin in thyroid eye disease. There's no correlation between orbital images and restriction. Sometimes the muscle is not that enlarged, but when you're in the surgical field, the muscle can be very, very tight. So that's why you have to be prepared for the worst and get ready to get a very, very tight muscle in surgery. Complications, overcorrections, much more than undercorrection. Inferior rectus is a muscle that usually gets slipped, so that's why you have to aim for undercorrection and do less. This is a patient who was referred to us like having an orbital tumor, but she had strabismus surgery and started having a double vision. There's a very tight inferior rectus muscle that was slipped. We were able to put it back, and patient did well. Used to use non-absorbable sutures, not anymore. Usually the non-absorbables get through conjunctiva, and that's why I prefer now just to resuture the muscle on the sclera, do as many stitches as much as they need to stay in place, but usually the non-absorbable suture get exposed through conjunctiva many years over and get a lot of inflammation. Small undercorrection is desirable. This is a patient, a cardiologist who had, this is after orbital decompression, very large vertical deviation. I did bilateral surgery, and even with an undercorrection, the patient was pretty happy just with a chin up and refused to have more surgeries. For large deviations, you do large inferior rectal recession. It was thought not to do more than 6. In this case, I did an 11 millimeter left inferior rectus recession, and I didn't cripple the muscle even by doing large inferior rectus recession. So if the muscle is really tight, you need to do more than it was expected to do. Usually the muscle is so tight that after suturing to the sclera, it comes back and pull back, and it ends up doing even farther back than what you plan to do. Speed recession, if the vertical deviations are moderate, this is pre and post. And lid retractions is another complication that usually you can avoid it by suturing the locus ligament. This patient, we did an inferior rectal recession and get an inferior lid retraction, which was fixed by the oculoplastic surgeon. Reoperations, 1 out of 4 patients, this is 2 or more surgeries. All of them were due to overcorrections, and none were due to undercorrections. So that's why you can say that strabismus surgery is effective in treating double vision in patients with thyroid eye disease. Intraoperative forced actions is an essential aspect of the treatment, and usually go for small undercorrections. You can get less complications.
Okay, Adolfo, thank you very much. There are a couple of questions now. One of them is, what is the surgical strategy in patients with myasthenia gravis and thyroid eye disease? What do you think?
Well, fortunately, that's not very common. The book says that it's 5% coexistence of both. In my series, I have as I said, near 200 cases. It's one aspect that you need to think about myasthenia, and is when you have an exotropia. Usually, thyroid eye disease, you don't get exo, you always get ESO or hyper. So whenever you get a big exotropia, or you get a very asymmetric lid retraction with a contralateral ptosis, you must think about that. In those situations, I'd rather go for steroids first, oral steroids, and see how the diplopia or the strabismus improves or not. And if not, you have to go for surgery anyway, and by forced actions, and as I said in the talk, need to do recessions that needs to be done to improve the alignment. But I don't go for surgery right away, but I would rather make a trial of oral steroids.
Okay. Another question is, have you ever performed muscle biopsy in uncertain cases of probable euthyroid strabismus to rule out other infiltrative causes?
No, usually in those cases, well, images, of course, that will help. And you go for the practical aspect. If you, as I said, it's better in these cases to go with general anesthesia, because if you do peribulbar anesthesia, you can change the forced actions test. But usually, if you have positive images, if you got positive forced actions, everything is obvious, I go right away for doing the strabismus surgery. And I only get muscle biopsy, is I think, of any other restrictive strabismus like CFOM, congenital fibrosis, extraocular muscle, any other mitochondrial disease. When you have a strong suspicion of any of those mitochondrial disease, you can get a muscle biopsy. Otherwise, you go ahead and do the surgery without any biopsy.
Tamara?
There are a few more questions asking how would you operate thyroid eye disease patients according to their antibody titer? Do you normalize them before? Do you wait? How do you go with the lab test and the surgery?
That's a very nice question. I had a couple of times a patient who was already in a chronic phase, was not active, but the endocrinologist said, stop the patient to having surgery because the antibodies were having a peak. And in those cases, even the cause is, of course, the inflammation caused by the antibodies, they follow a different path. So once you are sure that the orbital disease is chronic, it's not active, is stable, you can go ahead and do surgery even if the antibodies are horrible. The other way around, they can be euthyroid and the patient is active because they still have changes in measurements, they still have edema, they still have chemosis, they still have active signs. In those cases, you have to wait and do not do surgeries. So we don't decide, our indications are not decided by titers of antibodies, but by chronic or acute stage of the orbital disease. So we look locally through orbital disease, not through antibodies.
Another question is if you use tetrabenazine, there's a lower rate of orbital decompression. That really makes a big difference for the patients because a lot of them look really, even if they had some strabismus before, they look much worse after the orbital decompression. And do your plastic surgeons do something with the compression or tutuplast or things of that order to help not decompensate the strabismus that much after decompression?
Yeah, well, we're not using this kind of medication. It's not expensive here, but whenever you have a really bad exophthalmos or proptosis, the patients really not only wants they want cosmesis. So if you need to do a more aggressive orbital decompression, even if you get a worse strabismus, or even if you get double vision after our oculoplastic partners talk with the patient before that, and they are the ones who make the indication of doing certain type of decompression, because the patient usually wants to have a cosmetic result also. So they don't care, just go ahead and do the orbital decompression as much as they need, and then they pass it through the strabismologists, and we're the ones in charge of that, fixing the double vision of strabismus.
All right, great. So I think our thyroid patients are our most thankful, or one of our most thankful patients, and they're always so happy after the surgery. I think we're out of time. So I'd like to thank all the speakers for such fantastic and informative talks. We've learned so much from you once again. Special thanks to Alejandro and to Dan from the AAO. And just Alejandro, do you want any closure remarks before I pass it on to Jason Yam, who is from the Education Committee of IPOS, and he'll just make the closing remarks. Thank you so much, everyone.
Thank you, Tamara, and thank you all. And on behalf of the IPOS Education and Training Committee, I would like to thank again the Argentinian Council of Strabismus for co-organizing with us for this very wonderful and very insightful webinar on the restricted strabismus. And I would like to thank two moderators, Tamara and Alejandro, for the wonderful job. And also I would like to thank our 6 distinguished speakers for the very informative sharing. And to Dan and also Michael, the AO team, for the always very important support. And Dr. Sonel and Saiti for helping together on this webinar. And we shall announce our next webinar series in 2023, June. And may I take this opportunity now to wish you all a very blessed Christmas and a very prosperous and healthy year ahead, 2023. Thank you all. Bye-bye.
Thank you, Jason. Thank you very much. And on behalf of the Argentina team, I would like to thank the IPOSC and Tamara especially, and wish us luck for tomorrow, because
we're waiting. We want to see you celebrating and celebrate with you.
Thank you. Merry Christmas.